Good morning everyone, myself Shalini Mohanty, nursing tutor of Index Nursing College. Today I discuss about fluid and electrolyte. Terminologies: homeostatic, hydrostatic pressure, osmolarity, isotonic, hypertonic solution, embolism, catabolism. Total body water: intercellular fluid volume, extracellular fluid volume, intestinal fluid volume, intravascular fluid volume, salt, electrolyte solution, electrolyte and colloid balance, crystalloid, anion gap maintenance, replace substitution. Normal physiology: newborn infant में body fluid 80%, adult में 60 and adult female 50. Why woman has less than man if they are the same weight? The water content of adipose fat tissue is less than that of muscles, while women have more adipose tissue at the effect of feminine hormone. Body fluid are distributed in two distinct areas: intercellular fluid (ICR) 40% body weight, extracellular fluid 20% body weight. Extracellular fluid body weight, intestinal fluid 50% body weight, plasma 5% body weight. Total body water: intercellular 2 by 3 and intestinal fluid, plasma, lymph, transcellular fluid, extracellular fluid. Fluid and electrolyte balance between body and environment. Intake of fluid and electrolyte output. Kidney, gases, stomach, tract, skin, lungs. Output: lungs and skin 0.51 liter day. GI 100 by 150 ml day. And kidney. Regulation and fluid electrolyte. Passive transport mechanism, active transport mechanism. Passive transport mechanism: simple diffusion throughout lipid layer, simple diffusion throughout protein layer, facilitated or carrier mediated diffusion. Simple diffusion throughout lipid layer, simple diffusion throughout protein layer. This type of protein channel of protein solute cytoplasm, and facilitated or carrier mediated diffusion. Special types of passive transport: blood flow. This is a blood flow. Filtration, osmosis. Active transport: primary active transport, secondary active transport. Primary active transport, this type of primary active transport, and this secondary active transport. Normal hormonal regulation of fluid balance, aldosterone, antidiuretic hormone, natriuretic peptide. Aldosterone hormone secreted from the zona flow cell adrenal cortex, stimulate kidney. Stimulate kidney, retain sodium, retain water, secrete potassium. Antidiuretic hormone, also called arginine, vasopressin, EVP. ADH is produced in neuron cell bodies in supra and paraventricular nuclei of the hypothalamus and stored in posterior pituitary. Physiological function: promote the reabsorption of water in the collection duct. The narcotic peptide family. Our peptide of this family have been identified, including arterial natriuretic peptide, brain natriuretic peptide, C-type natriuretic peptide, urodilation function, diuretic and natriuretic action. Arterial natriuretic peptide function. This is a flow chart of arterial natriuretic peptide function. The sensation of thirst. Conscious desire of water major factor that determines fluid intake. Initiated by osmosis receptor in hypothalamus that are stimulated by increase in osmotic pressure of body fluids, also stimulated by a decrease in the pressure throughout the receptor of baroreceptor. Os- Osmoreceptor stimulate EVP secretion and thrust. The vascular organ of the lamina terminals contain osmoreceptor neuron, also the subchorionic organs and the median peptic. These cells protect, project to the paraventricular nuclei and suprahepatic nuclei to produce AVP secretion. The regulation of thrust reaction. The stimulate sensed by osmoreceptor, not a change in the extracellular fluid osmolality, but a change in osmoreceptor neuron size or the same intracellular substance size. Compression of osmotic and hypovolemic thirst. The flow chart of abnormalities in the regulation of body fluid. Extracellular fluid volume defect. Extracellular fluid volume excess. Extracellular fluid volume shift. Extracellular fluid volume defect. A decrease in intravascular and intestinal fluid. It is a common and serious fluid balance that results in vascular fluid volume loss, hypovolemia. Risk factor: diabetes, ketoacidosis, hemorrhage, difficulty in swallowing, age, severe mentality ill patient. Laboratory findings: increase osmolality, increase or normal serum sodium level, then hyperglycemia 120 mg, increase passive gravity of urine, ablated hematology, increase specific gravity. Management of dehydration, pharmacologic management, dietary management, nursing diagnosis and collaborative problems, nursing intervention. False precaution: access the orthostatic hypotension, access muscle strength in legs, orient the patient of the environment, remind the patient to call for help before getting out of bed or a chair. Help the patient get out of bed or a chair. Provide or remind the patient to use a walker or cane for ambulating. Help the incontinent patient toilet every 1 to 2 hours. Clean up spills immediately. Provide adequate lighting at the same time, especially at night. Keep the call light within reach and ensure that the patient can use it. Place the bed in the lowest position with the brakes locked. Place objects that the patient needs within reach. Ensure that adequate hand rule and present in the patient room, bathroom, and hall. Encourage family member or significant other to stay with the patient. Extracellular fluid volume access ECFVE is increased fluid retention in the intravascular and intestinal space. Extracellular fluid volume shift is basically a change in the location of extracellular fluid between the intercellular and the intestinal space. Electrolyte balance and imbalance. Sodium hypothermia and hypotonia. Hyponatremia definition, commonly defined as the serum sodium concentration 135. Hypothermia represents a relative excess of water in relation to sodium. Hyponatremia is the common electrolyte disorder. Acute hypothermia developing over 48 hours or less are subject to more severe degree cerebral edema. Sodium level is less than 105. The mortality is over 50%. Chronic hypothermia developing over more than 48 hours experience nuclear degree of cerebral edema. Types: hypovolemic hyponatremia, hypovolemic hyponatremia, hypervolemic hyponatremia, redistribute hyponatremia, hyponatremia. Hypovolemic hyponatremia develop as sodium as free water as loss and or placed in inappropriately hypotonic food. Sodium can be lost through renal or non-renal routes. Non-renal loss. GI losses, vomiting, diarrhea, fistulas, pancreatitis, excessive sweating. Third, spacing of fluid, ascites, periodontitis, pancreatitis, and burns, cerebral salt wasting syndrome, traumatic brain injury, aneurysmal, subarachnoid hemorrhage, and intracranial surgery must distinguished from SIADH. Renal loss, acute or chronic renal insufficiency, diabetics. Hypovolemic hyponatremia, normal sodium stores and total body excess of free water. Physiogenic polydipsia, often in cyclic patients. Administration of hypotonic intravenous 5% or irrigation fluid sorbitol glycerin in the immediate post-operative period. Administration of hypotonic maintenance intravenous fluid. Infant who may be given inappropriate amount of free water, bowel preparation before colonoscopy or colorectal surgery. Hypervolemic hyponatremia. Total body sodium increase and and TBW increase to a greater extent can be renal or non-renal, acute or chronic renal failure. Dysfunctional kidney are unable to extract the ingested sodium load. Cirrhosis, congestive heart failure, or nephrotic syndrome. Hypervolemic hyponatremia, total body sodium increase. Redistributive hyponatremia, water shift from the intercellular to the extracellular compartment with the resultant dilution of sodium. The TVP and total body sodium are unchanged. This condition occurs with hyperglycemia. Administration of mannitol. Hyponatremia is used due to water defect, excess water loss, example heat exposure, diabetes insipidus, impaired thirst, example primary hypodyspia, comatose, excessive retention. Clinical features: excessive thirst, polyuria, nausea, muscular weakness, neuromuscular irritability, altered mental status, focal, neurological deficient, occasionally coma or seizures. Treatment: correct water deficient plasma 140 body weight in kg. Rate of correction: acute hypernatremia 1 mn hour. Renal loss: acute or chronic renal insufficiency diuretic. Evolemic hyponatremia, normal sodium stores and a total body excess of free water. Physiogenic polydipsia, often in psychiatric patient. Administration of hypotonic intravenous hypertension or irrigation fluid, sorbitol, glycerin in the immediate postoperative period. Administration of hypotonic maintenance intravenous fluid, infant who may have been given inappropriate amount of free water, bowel preparation before colonoscopy or colorectal surgery. Hypovolemic hyponatremia, total body sodium increase and TWP increase together extent. Can be renal or non-renal, acute chronic renal failure. Dysfunctional kidney are unable to extract the ingested sodium load. Cirrhosis, congestive heart failure or nephrotic syndrome. Hypovolemic hyponatremia, total body sodium increase, TWP increase or together extreme. Redistribute hyperchromic, water shift from the intercellular to the extracellular compartment with the resultant dilution of sodium, the TBW. The total body sodium are unchanged. This condition occurs with hyperglycemia. Administration of mannitol. Hyponatremia is usually due to water deficient, excess water. Example heat exposure, diabetes insipidus, impaired thirst, primary hypodyspia, comatose, excessive reaction. Clinical features: excess thrust, polyuria, nausea, muscular weakness, neuromuscular irritability, alternate mental status, focal neurological deficient, occasionally coma or seizure. Treatment: correct water deficient water plasma. Rate of correction: acute hyperthermia, chronic hyperthermia 1 m liter hour and 10 over 24 hour. Rapid correction may lead to cerebral edema. Potassium hypokalemia, hyperkalemia. Calcium hypokalemia and hyperkalemia. Phosphorus hypophosphatemia and hyperphosphatemia. Magnesium hypomagnesemia and hypermagnesemia.